Can you hear me out there?
Yes.
Okay, come on the video because I need to see your face. Okay. Kenneth, do you see her? Okay, hold on a second. Okay, now just give me a 5 count. No, I need you to say it.
5, 4, 3, 2, 1.
Thank you. You can come on in.
I'll turn the video off.
That's all we're doing. Just leave your video where it is. Okay. 1, 2, 1, 2. 1, 2, 1, 2. 1, 2, 1, 2. 1, 2, 1, 2. 1, 2, 1, 2. Okay. 1, 2, 1, 2. 1, 2, 1, 2. 1, 2, 1, 2. 1, 2, 1, 2. 1, 2, 1, 2. 1, 2, 1, 2. 1, 2, 1, 2. 1, 2, 1, 2. 1, 2, 1, 2. 1, 2, 1, 2. 1, 2, 1, 2. 1, 2, 1, 2. 1, 2, 1, 2. 1, 2, 1, 2. We good, Kenneth? Thank you.
All right. Good morning. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today is Monday, May 11th, 2026. The time is 10:03 a.m. We are in room 500 of the John A. Wilson Building. This is a hybrid hearing where our government witnesses will be testifying in person. However, the hearing can be viewed live on cable channel 13, as well as on my YouTube page at CMC Henderson. This hearing was rescheduled from its original date on April 29th. This is part 2 of the budget oversight hearings for the proposed FY27 budgets for the Office of the Deputy Mayor for Health and Human Services, as well as the Department of Healthcare Finance. On Monday, April 27th, we heard from public witnesses. We heard from nearly 70 public witnesses who showed up to testify, many showing strong support for continuing the Medicaid and Alliance programs. Some other issues raised included implementation of the federal work requirements for SNAP and Medicaid, outreach for substance use treatment, and concerns about the proposed cuts to direct medical education, which affects the district's teaching hospitals and residents' salaries. Today, we will hear from our government witness, Deputy Mayor Wayne Turnage, who wears 2 hats as the Deputy Mayor as well as the Director of Healthcare Finance. We're going to start with DMHHS and then we'll move to Healthcare Finance thereafter. The Office of the Deputy Mayor for Health and Human Services supports the mayor in coordinating benefits, goods, and services across multiple agencies to ensure that residents with and without disabilities can lead healthy, productive lives. DMHHS manages 2 special initiatives, Age Friendly DC and the Interagency Council on Homelessness. They also oversee the administration's encampment clearings and cleanup efforts. The Department of Healthcare Finance provides healthcare services to low-income children, adults, and elderly and persons with disabilities. More than 290,000 district residents, approximately 40% of all residents, receive their health services through DHCF's Medicaid and Alliance programs. I don't see any of my colleagues with me now, but I'll certainly turn to them should they join us. Deputy Mayor Turnage, before you begin, I need to swear you in, as well as anyone on your team who may speak today. Just makes it more efficient, so if everybody could raise their right hand. Do you swear or affirm under penalty of law that testimony you're about to provide to the Council of the District of Columbia and this committee is the truth, the whole truth, and nothing but the truth?
Do.
Great. Deputy Mayor, when you're ready.
Good morning, Chairperson Henderson and members of the committee. I am Wayne Turnage, Deputy Mayor of Health and Human Services and the Director of the Department of Healthcare Finance. I am here, as you noted, to briefly report on the fiscal year 2027 budget for the Deputy Mayor's office and later the Department of Healthcare Finance. But before I begin, I do want to thank you for your kindness in rescheduling this meeting to allow me time with my family and what has been a difficult past few weeks. So your thoughtfulness is very much appreciated. As is custom, I will start with the budget for the Deputy Mayor's office. And as you know, that's a very small operation, just over $2 million. I am joined by my team, my wonderful team of the Chief of Staff, Rachel Joseph, and our Policy Director, Brian Harrison, and the gentleman who expertly runs our encampment program, Jamal Weldon. We have submitted written testimony. It is, as you noted, a very small budget. The most significant consequence has been the defunding of the ICH function. And if we can, if you would like a summary of the budget highlights, Rachel Joseph can prepare such. Otherwise, we can go straight to any questions that you might have, given the small nature of the budget.
Okay. All right. So we'll get some questions in. I don't have that many for our DMHHS. So Deputy Mayor, let's actually start on Interagency Council on Homelessness because that is the biggest change in this particular budget. The proposed FY27 budget reduces the ICH staff by 7 FTEs, 5 of which are currently filled. These positions are currently located within the Department of Health and Human Services budget. Department of Human Services budget. At Performance Oversight, DMHHS testified that you had just brought on 4 new ICH staff to kickstart the update to its 2024 priorities. What changed?
What changed was the lack of dollars to pay for the positions. The agency that funds those positions is under significant stress and given the other challenges that they had. And so we, at the end of the day, decided that we should do the best we can to preserve as much as we can of the funding agency. And as a result, those positions were eliminated.
Okay, so after these reductions take effect in October, how many FTEs would be remaining if the council made no changes?
One, Rachel has been.
It's one FTE, and just to add, it would be the director of the ICH. Though we do also have 2 vacant positions in DMHHS that we could repurpose to support ICH if necessary. I do want to add, you had asked about the strategic plan for the ICH.
Yeah.
That they expect that to be done in June. It goes to the ICH full council at the June meeting. And so the staff who were brought on, 3 of them were brought on in NTE positions,
Okay.
recognizing that they could be potentially short-term positions
Okay,
to support the work to get us through the end of the fiscal year. So we anticipate that the strategic plan will be completed with the help of those staff before we have to get rid of it.
okay. All right, I'm also being asked that you guys either move the mics closer to you or speak a little bit louder. Are there federal requirements for the ICH regarding reporting and data analysis? And are we concerned that, only leaving the director would impede that work?
Yeah, I'm not aware of any specific federal requirement, but we do, I don't want to dismiss the difficulty that, that the ICH director will have in continuing to do the kind of work that she has expertly provided. It will be a challenge with no staff, and frankly, we will have to huddle with her to see how we can best move forward in the absence of the support that she customarily has.
Okay. The proposed budget for DMHHS transfers 1 FTE for a senior advisor position from DMHHS to the deputy mayor for education. In your pre-hearing responses, you all indicated that this position was already located within the DME and that this budget is reflecting where the position really lies. Why was it originally placed with DMHHS?
So this happened prior to my coming on as chief of staff, but my understanding is that it was a mistake in moving, the position moved from the city administrator's office, and it was supposed to move to DME, but somehow it was put in our budget so that the person has been sitting in DME, working for DME, and this just reflects putting the position where it rightfully sits.
Okay. This is just sort of a reflection as somebody who used to spend a lot of time on the Deputy Mayor for Education's budget as the Committee Director for Committee on Education. The Health and Human Services cluster has a larger portion of this government's finances, and you have less people coordinating that work.
It's called efficiency.
Oh, okay. Okay. All right. So you all proposed 2 new FTE positions, a public affairs specialist and a data and visualization specialist. What would your public affairs specialist be doing?
So those are positions that were created again prior to my coming on, and we have used them. We haven't filled them because of mid-year cuts for vacancy savings. And I think that the truth is that it probably would not be a public affairs specialist once we go to fill it. It's not a new position.
Okay.
I think that was incorrectly indicated in the pre-hearing responses. It was there for this fiscal year. And when I came in and started assessing what was the staffing in the office, I decided that we did not need to fill that immediately and we could use those vacancy savings for mid-year cuts. But having the position to be able to adjust, and as you mentioned, we function on a very small staff, but having that position to be able to create the workload that we need even to support the ICH, potentially to support the fact that we don't have a director position at healthcare finance. So that is
Okay.
the plan for that position.
I mean, I'm not picking on you guys in terms of that altogether, but this is something I've thought, right? Why does every deputy mayor need their own comms person in addition to every agency having its own comms person? In addition to every agency having their own data and visualization people, you also need one in the deputy mayor's office. You see what I'm saying? Like the redundancy.
The data and visualization person was specifically for ICH purposes.
Oh, okay.
So I think, if the cuts move forward to the ICH, that would probably be a good repurposing of that position to support. I don't know whether it would be specifically data and visualization or solely data and visualization, but to support Director Silla.
Okay. So they tell us America's 50 is happening and we should celebrate. Yay, America. How are you all planning for this summer and expected higher scrutiny on encampments by the federal government?
That's a very good question. There has been obviously a subtle shift in our strategy over time. When I first, I guess it was 2018, we were basically trying to manage encampments to keep them from becoming challenges for both the residents in the encampments and the residents of the city. We tried to move people out, but if we didn't, we wanted to make sure the encampments were clean and the residents living in those encampments were safe. We've shifted that posture with the expansion of shelter beds. So with the ability to now offer a shelter bed for every person who is living in an encampment, we take the position that encampments should not be allowed on the streets of the city. So Jamal and his team will be, as they have been, seeking to close encampments where they encounter them and do all of the pre-closure work, pre-cleanup work, with the goal of getting people to move to shelter. Will we close every encampment? The answer is obviously no, because some people just don't want to go inside and they will just move to another location and create another engagement for Jamal and his team. So we do expect greater scrutiny this summer. And we are, frankly, a little worried about how that scrutiny might play out. So, and I'll let Jamal address, what they're doing and how they're doing it, because he and his team are just excellent at what they do. And, but we are a little concerned that, with the emphasis on the birthday of this country, the 250th, that there could be a push to make sure the streets are absolutely free and clear of all encampments. And that's a heavy lift. We will do what we can prior to that time, but it will be difficult to close every encampment and move people into shelter, particularly in the summertime when they don't want to go to shelter. Are you going to add anything?
Yes. Good morning again, Councilwoman Henderson and all. With the encampment team and myself, what we are looking to do is still continue our collaboration with our interagency partners to work towards the outreach of, as the DM stated, advising residents and urging them to seek shelter and a variety of other connected services as may be applicable to their situations. We're going to continue to identify locations at the highest health and safety concerns, of course, first and foremost, those that are impeding certain areas of the city from their intended use or causing, again, extreme safety concerns such as fire hazards, different things such as that. Our biohazard team will still continue to work with us to address certain issues intermittently. We try to mitigate as much as possible having to be too frequent with any particular site. We try to work with the outreach partners to see if there's anything that we can do to support their efforts that would be more successful. What we have seen over the past, I'll say 4 to 5 years, is definitely a significant drop in the number of encamped residents. We're currently tracking in the mid-80s of encamped residents, whereas about 3 years ago, we had well over 120. Same thing with our sites. Our sites have decreased to about mid-60s, where we had at one point over 100 physical addresses throughout the city. And many of those locations that are currently residing in the district are more so 1 or 2 residents per encampment, as opposed to the larger 10 plus that we had experienced years past. So we're going to continue with that effort and see how best we can support, of course, the service effort, but also addressing the health and safety concerns.
I mean, 60 locations still sounds like a lot.
It is still significant, but if we go back to, again, about 3 or 4 years ago, we were well in the hundreds. Actually, and around that time, we were closer to 200 residents on average that were living in encampments. So I think we have seen a significant decrease, but a lot of that has gone to, one, the consistency of our enforcement of the protocol, but also the human services efforts with our community partners, our interagency partners, DHS, DBH, and being able to connect those residents while building a rapport to their viable resources.
Okay.
If you recall, we had one encampment that had like 75 people in it. And we closed that. We closed the 4 largest encampments in the city. We did it humanely. We did it with the emphasis on putting people actually in apartments. When for the first 3, I think we will put over 100 people in apartments.
Yeah. I was going to ask you about that in terms of, I guess we called it a pilot.
Yeah.
Are we still tracking those individuals, Jamal?
Yes, still tracking 115 individuals that were housed and still receiving services with care. The primary tracking of that does fall under our DHS partners. But yes, that pilot did turn out to be very successful with our efforts. There were 4 major sites that were connected to that, and the residents who agreed to services, we were able to assist.
How many of them are still housed in apartments?
The last check that I had, there was still 115, but I will have to follow up with our DHS partners for accurate count.
Okay. Deputy Mayor, during performance oversight, you testified that you guys were working with the mayor to consider removing the cap on the beds filled at the Aston.
Yeah.
I talked a little bit about, I guess, our bridge housing strategy with Director Pierre of DHS. So we have the Aston, we have E Street, which is not at capacity. And then there's funding in the budget for a 3rd location that site yet to be identified. Is that an accurate representation?
Yes.
Okay. So what's the word on the Aston?
I would say that the concern about expanding that still remains. It has been a very successful program, and we have not been able to overcome our concerns that if we expand it appreciably, that it may be difficult to manage. And so I think until we are comfortable with the notion that it can be done and done in a way that does not create problems for the residents in the Aston and certainly the surrounding community, there will not be a push from the mayor's office and the deputy mayor's office to expand the number of beds there.
Okay. Then status on a 3rd location?
Yeah, to be honest, I have not been intimately involved in the site location. DHS and the CA work very closely on that. I know there were a couple of sites that we contemplated and they were just too big. And I'd have to touch base with the CA, or maybe Rachel knows what the next site, might be on the agenda.
DGS has a broker that is supporting them in trying to find locations, and we've been looking at them as they come up. And so far, there, as the deputy mayor said, that we haven't found one that has the right size and the right configuration.
Okay. I guess I'm curious in terms of the thought around a 3rd site when the first 2 are not at capacity.
Well, I think the best way to look at that, I understand your concern, is
It's a concern. It's a question, right? I mean, like in terms of like.
It's a legitimate question. Our position currently is to get to capacity in that site could be a challenge. Not in terms of the ability to put people in, but the ability to manage it. So we kind of treat it as being at capacity from a programming standpoint. And if we decide to go, to a larger number of beds, then we'd have to sort of resolve, the challenges that could come from expanding that site to, more than 100 beds.
No. I guess my question is, for East Street, is that also going to have a 100-bed cap as well? Because what I don't want to happen is sort of people feeling as though
No, and they're
Foggy Bottom is getting special treatment. You get what I'm saying?
No, I hear you. I don't think there's a capacity limitation at East Street.
No, and they're on their way they're working hard to fill those beds.
Yeah.
Yeah, there's an infrastructure issue that they've dealt with and a programming issue that, they feel they're ready to deal with a larger number. So those beds will be filled.
Okay. In this same vein, something that came up at the DHS hearing was around bridge housing is supposed to be temporary, but the way that the current budget is set up, we have no place to send someone to after they reach their cap, or not cap, but allotted time in bridge housing, because the budget doesn't include any new money for vouchers. So, what happens next?
I will sort of defer to the experts at DHS. That is a sticky issue, a very real problem. And so rather than opine about what I think will happen, I will certainly talk to Director Pierre and get her views on how they will manage that situation, because it occurs not only in bridge housing, I think it occurs in the short-term family housing as well.
Right.
So that's something that they struggle with on a regular basis. Very complicated problem. It's probably the most, I don't say probably, in all my years, this is the most difficult public policy issue that I've ever had to confront.
Housing? Housing?
Yes, housing, encampments, shelter living. It's very challenging for a number of reasons. And, the district probably spends more per capita on these services than any city in the country on a per capita basis. And it always feels as if we're not doing enough. And so I have to remind myself that if you go to other cities, they don't have anything close to what we're doing. But yet we feel sometimes that we aren't doing enough. And it's because the problems are so intractable, and you're dealing with human beings who are living in some very, very tough situations. So yeah, it's by far the most challenging public policy issue that I've ever faced in 40 years of working.
Okay. Sort of in that same vein, I want to ask you about CCNV. So a few weeks ago, I was talking to the leadership over at Unity Clinic, and one of the concerns that they raised was that the plans for the new CCNV would not include a health clinic on site. And I think there might be some tensions there between the CCNV folks and then us. But if we do our own sort of take a few minutes virtual survey of the area, if there is no health clinic on site, it is a very long distance for someone to go to the next closest, whether it be FQHC or something to that effect.
Sure.
Can we commit that DMHHS will continue to monitor this project to ensure that the health clinic on site? I mean, I know it's a partnership, but we should have some say here, no?
Yeah, I think it would be a mistake if there's no health clinic there. The rather trenchant differences on this between the health clinic and CCNV, I think, will be resolved. I think they have to be resolved, and I think the model should include a health clinic from my personal view. And so I certainly will, to the extent that I have any influence, I will try to use that influence to make sure there are some services, health services in the facility. And I think, it's right now people are in their own corners, but my hope is that as we get closer and closer to a to move from design to build to operation, that whatever differences exist about whether or not there should be a clinic, that can be amicably resolved.
Okay. So my staff has been participating in your regular meetings with the leadership and staff at St. Elizabeth's Hospital to address some of the ongoing concerns and challenges at that site regarding staff safety and patient safety. From your perspective, how have those meetings been going thus far?
Oh, I think they've been going extremely well. We've given money to address some of the infrastructure issues. I think the reprogramming is probably with you, if not. Melody knows what a reprogramming is.
It's been approved. The reprogramming has been approved, and it's,
Adrian, what's up high, and the AFO comes.
They could spend against it already.
I think we're doing really well. We're not done, but they've made tremendous progress. Dr. Bazran and Rachel have been just doing a wonderful job, and the staff that we've met with at the hospital, they seem to be in agreement that we're seeing significant progress. More work has to be done, but I think if you brought that staff in and had another hearing, it would be very different than the one you had some time ago.
I think they might appreciate the fact that there have been conversations, but the resources aren't necessarily flowing in the same way. I mean,
Well,
it was a surprise to me to get the budget and see a $14 million reduction for St. Elizabeth's Hospital in the budget. Not additional resources, but right, yes, vacancy savings. And
Right.
also they've got need for new systems. They still have a bunch of hiring that needs to happen. And in the interim of hiring, they should be hiring a contractor to get on some of their work order backlog. They have a need for additional security. Like, I mean,
A bunch of those
you
issues
know all of these
a bunch of those
things.
issues are being addressed. Rome wasn't built in a day. I mean, there were, you know.
Something, no? I mean, like,
I think we've made, I do think we've made some significant progress. Like I said, there are things to be done. On the hiring front, I think that, we've made significant progress on hiring. Rachel, you have the details. But when I sit in those meetings, I get a sense from the staff, my staff and their staff, that they like the progress that's being made and they want to keep pushing for more.
Rachel.
So they have made significant progress on hiring. I don't have those exact numbers with me right now, but I'm happy to share them, although your team is participating in the meetings and knows.
Yeah, no, I got the slide presentation during their hearing.
Yeah, I do think there's some frustration at the moment that we don't have the next meeting scheduled, and that I would request some grace from the folks at St. Elizabeth's, given what both the deputy mayor and I have experienced in the last few weeks. And we will get that scheduled as soon as he is back full time in the office. And we will get back on a every 3 week schedule. There just have been a variety of personal reasons that we've had to either cancel or reschedule. And I know that the staff over there are pretty frustrated about that. And I will make sure that we get that back on track.
Yeah. I mean, frustrations understood, but sometimes frustrations are just from lack of information. So,
Yeah. Yep.
You know, if we just communicate with folks. Now, Deputy Mayor, on the same vein, well, it's a little bit different, but I want to ask about SNAP and Medicaid work requirements. So SNAP work requirements will start in effect in June. Medicaid will start in January.
Right.
And I still have community partners and providers who are looking for information of how to support their clients through this time. And I'm told there's working groups happening, right? I'm told people are meeting and having conversations about how best to do this. And yet it's May 11th, and there still has been no external communication with the people who are closest to the very clients who we want to ensure are able to keep their benefits. And I think it's so important, particularly on the Medicaid side, because Once you lose Medicaid, there is no safety net after the safety net.
That's correct.
Like, there's no other program that we could say slide you in. And I doubt that this administration is going to attempt a TANF local situation when it comes to Medicaid.
That's accurate.
Okay.
So let me say, and you know, these are a lot of questions for a $2 million budget, but you know, we
have responsibility of the whole cluster. I know you don't like that. I know you don't like it. And yet.
No, but let me say on the Medicaid side, Melissa Bird, and she can talk about this when DHCF is up. She is heading up a very, very detailed process that will result in us standing up a work program that is broadly communicated about how you meet the work requirements for the Medicaid program. Now.
Right, that's in January.
That's in January.
I have a lot of faith in Melissa.
Yeah.
You should pay her more.
Yeah,
The point still being is that SNAP starts first.
Yeah, SNAP starts first. And I hate to be a pessimist, but the city will have challenges with both work requirements because of the exemptions that have existed in the past. So you have a population that benefits from SNAP into a lesser degree Medicaid that have been given grace about not having to pursue work requirements.
Mm-hmm.
So that is whatever process we put in place, however much it's communicated, we have to overcome that factor. And I think that is a challenge that people should be concerned about. We will certainly do our absolute best to make sure people know how to interact with the system, to report their work requirements. But my concern is there will be many people who will not meet the work requirements, not because they don't know how to interact with the system, it's because they don't have the appropriate work activities.
Right. That's my part in terms of my understanding is that there's been some work group going on with Department of Employment Services, Department of Human Services, et cetera.
And the city administrator, I've not been here for the last couple of weeks, but I've glanced at the calendar and there's several long work requirement meetings. And in fact, I will need to get up to speed when I come back to work next week full time. I will need to get up to speed with both Melissa and her team and Director Pierre and her team on sort of what the scope of work is and where we are in the process and how we will monitor our progress to make sure on the administrative side there is no failing. But again, we can do everything perfectly.
Yep.
And still have a large number of people who don't qualify because of reasons we cannot control. But we will work very hard to make sure that the number of people who ideally we would like nobody to lose benefits on the Medicaid or the SNAP side because they fail to meet a work requirement. So that is our goal.
I think you are correct. Some of it are things that we can't control. Some of it is around expectation setting. As we had this conversation when we talked about TANF, right? And doing the step downs. People don't actually think that we're going to do it.
Correct.
So they don't take the necessary steps because they're like, oh, well, they've been saying that they're going to do this for 10 years now, and they never have. And I feel like this is going to be kind of a shock for folks, especially if you are relying on all three benefits.
Yeah.
You have to have
absolutely.
Something to hold on to any of them.
Yeah.
So the Venn diagram of who would lose benefits for all three there's not overlap because TANF, the SNAP requirements are for people without dependents. TANF would be with dependents. So it's a much, there's more overlap between the Medicaid and the SNAP. And we are very focused on that, very focused on trying to identify who those folks are. But the TANF one is sort of it is a concern, but it is separate because it's not, those are folks with dependents. So that's just one clarification to make. And we are, DHS and the team have been working really hard on the communications. Melissa can speak more to this when DHCF comes up to testify, but they have a new contract in place for communications. DHS is going to be using that also. And we have some work products that are due this week to the city administrator to be able to identify and understand who the affected people will be. And it's on a rolling basis, which helps a little bit. You know, it's not
All at once.
at once.
Right.
And there's a 3-month grace period. Like, so you go in and you recertify for your staff benefits. At that point, you're told you have to meet work or volunteer requirements, and you have 3 months in order to get into that position, posture, and to show that you can, so that we can certify that you're either working or volunteering.
Right.
So that gives us a little bit more time than it's not a hard and fast June 1st start date. And we are working very closely with DME, DOES, and ServDC to make sure that we have the structures in place so that as folks come in to recertify, they are being put into the pathways that will help them maintain their benefits.
Okay.
The problem on the Medicaid side, and I haven't looked at the work requirement regulations in a while, but as I recall, when I first looked at them, the thing that alarmed me was for new applicants, I think they already have to have the work requirements met before they qualify when they first apply. So the communication, if that's still true, the communication will have to be extensive, because you could just come to apply for healthcare benefits thinking that I'm eligible, I need healthcare benefits, I've lost my insurance because I've had a drop in income and lost my job. I'm just going to go show up and apply for health benefits. And then if we calculate how much time you spend in a work activity and you haven't done that prior to coming to apply, I believe you will be not eligible. So that's something, if that requirement still exists, we have to figure out how we can tailor our communications to make sure people understand, even though you don't need Medicare at the moment, if you think you're going to need it, these are the work activities that you need to be able to show if you're not exempt from those activities.
Okay. Final question on the DMHHS front. So as you may be aware, the Office of Planning's budget proposes to zero out the Office of Food Policy, as well as repeal the entire Food Policy Council, which is made up of volunteer experts who serve the city. We've had both for the past decade. If the council were able to restore this cut, we would likely relocate the office out of Office of Planning, because it's very clear that the Office of Planning does not believe that food policy is a core function of its work. Although you can't plan a neighborhood without a grocery store, although we seem to be doing that a lot in DC. Anywho, to the extent that you're familiar with the Office of Food Policy and the Food Policy Council's work, do you believe that DMHHS would be an appropriate location for it?
To be honest, I'm not very familiar with their work, but certainly given our focus on making sure people don't go hungry in this city, if that is the will of the council to locate it in DMHHS, either me or my replacement, would welcome the challenge.
Great. All right. We haven't made a decision there yet, but it can't stay at OP. It has to move. All right. That's all the questions I have for DMHHS. Let's do a 3-minute break really quick so we could switch out, and then we'll get to healthcare finance. Thank you to the DMHHS folks. Okay, we're back for the portion on Department of Healthcare Finance. I'm just going to stay at the top. Director Turnage now. And also for the purposes of the public, when we rescheduled the hearing, my staff and I had a very long conversation with healthcare finance staff in advance of this hearing. So if you feel like we're not pressing enough or asking enough in terms of questions, a lot of our questions we did get answered. There are some things that I'm just going to say for purposes of, well, you weren't there, Wayne, but everybody else who was there, it is going to be a repeat question, but it is a repeat question because we want to make sure that we get the response on the record. Our meeting was not on the record. Okay, Deputy Mayor, when you're ready. Oh, just got to turn your mic on.
Okay. Good morning again. It's my pleasure to report on the mayor's proposed fiscal year 2027 budget and financial plan for the District of Columbia. I am joined by my very experienced and hardworking team, both at the table and in the room. As you know, Melissa Bird is our Senior Deputy and Medicaid Director. We have a wonderful new interim Senior Deputy for Finance who now steps in the considerable footprint that was left by the departure of Angelique Martin, but I can tell you, having worked with April closely, she has big feet and will step in that footprint very, very well. Eugene Sims is around here somewhere. He's our policy director and he's our go-to guy on any question that we get. And sometimes when we tell you we need a minute to answer your question, that's generally the time we are trying to run down Eugene. We have Dr. Charmaine LeBird, our Chief Medical Officer. Lots of experience with managed care, which is very helpful. And of course, we have Melanie Williamson operating in a dual role, both as my Chief of Staff and the Chief Operating Officer. And around the room are our administrators and other staff with various subject matter expertise who may be called to the table depending upon the questions. We have labored long hours, as we always do during this time, working with our tremendous agency fiscal officer, Darren Schaefer, and to analyze and put forth written proposals to the mayor's office that they evaluate, send back to us, tell us do more, and we do that until we come to a budget that you had the pleasure of receiving when it was submitted. I will start by going to slide 4 because I think it's always helpful to sort of set the tone for the challenges that the mayor faced in putting this budget together. And it had multiple challenges. The most formidable was the existence of a citywide $1.1 billion budget gap, which I believe is historic. I don't think the budget gap has ever been that large. And we calculate the budget gap by looking at the previous year's approved budget as a starting point, and then we determine what it would cost to do those same policies and programs, what it would cost in the next year's budget, and that was a $1.1 billion budget hole. If you look at the graph on page 4, you can see that the principal reason for this problem was a $700 million decline in revenue, which was a function of slower revenue growth, smaller forecasted and future revenue surpluses, and of course the decline in the federal workforce. And then that's just on the revenue side of the budget. The expense side actually exacerbated the problem because the projected changes for that side of the budget would have added about $450 million to the approved budget if left unaddressed. So what did the mayor do? She submitted a budget of about $11.8 billion, which is 95% of the 2026 approved budget. And she did this by very strategically producing about $800 million in savings. And then there was some revised revenue estimates, some additional surpluses, and some other small changes. And as a result of that effort, the historic budget gap was closed. I will turn to the next slide. And, you know, we've gotten a lot of questions about what it will take to put Alliance back like it was. I think what needs to be recognized is how much work was done to stave off the additional Alliance cuts that were already in the financial plan for this year. With the mayor was able to maintain eligibility for adults who are greater than 24% of federal poverty, who were slated to be eliminated. She maintained eligibility for adults in fiscal year 27 who only had one-time funding in fiscal year 26. And those were those who were newly enrolled in 26 between the ages of 21 to 26. And also enrollees who turned 21 in fiscal year 26 and aged out of the children's program. Those populations were all subject to lose their benefits, but the mayor's efforts were instrumental in her budget and keeping those benefits intact. And as you know, you were sort of leading the way on the notion of reinstating dental and vision benefits, and those things were done. And the total cost to reinstate was about $30 million in local funds. If you go to the next slide, you know, one of the challenges with Medicaid is always the local, a projected local cost increase because of factors that if you're going to have a Medicaid program, you can't easily control. And that is, you know, rising prices with providers, you know, given our eligibility level, there'll be pressures on the eligibility on the enrollment side. We don't expand benefits a lot, but the price of those benefits do change even if we don't add new benefits. And so there was a $172 million gap across Medicaid, or a projected spending growth, most of which was in DHCF, 19% of which was in two other agencies. And if you asked a question, you said, well, $172 million in DHCF's budget is not insignificant, but it's, you know, it's a $5 billion budget. If you take the 172 as, and for what it is a local supplement, and gross it up, as Darren would say, to what it would cost when you include federal dollars, and that's $860 million. So if we did not fund that, those spending increases, it would have taken $860 million out of the healthcare system in the city. Obviously, we did not want to do that. If you jump to slide 8, I want to talk very little bit about how our budget was constructed. As you see on that table, the proposed budget for DHCF is roughly $5.3 billion in total funds, that's federal and local. Now, this is $169 million less than the approved budget for fiscal year 26, but our actuary in April tell me this is a function of the fact that we have a projected lower spending rate, lower spending for the average commercial rate, which is a funding mechanism for the hospitals that we'll talk a little bit more about later. And also the budget accounts for the lower Medicaid enrollments for people who are now in Healthy DC, about 15,000 former Medicaid beneficiaries. And also there are 2,000 former Medicaid beneficiaries who are over the eligibility level, who also now are on the exchange. Those factors help push the total spending for Medicaid proposed for 27 below what we were spending in 26. But if you look at local funds, there's a $64 million increase. Three factors drive that. We are maintaining coverage levels, as we talked about earlier. And you say, well, if you're maintaining the coverage levels, why does that drive up costs? Well, we're seeing a shift in the healthcare costs of our population. They are getting older, they have more chronic disease. And so when you maintain eligibility, that population becomes, on a unit basis, more expensive to serve. We've added dental and vision benefits, as we discussed earlier. And the federal government, for some reason, decided to lower its contribution to DCAS, and we had to backfill that. Those things drove a $64 million increase, which was somewhat, as you will see on the next page. If you go to the next page, we talk about what the local changes. If you look at first, if you look at the total change in our budget, there's a negative $205 million change, again, due to the lower ACR payments. But locally, we have a plus $36 million increase because of the higher costs associated with Medicaid and Alliance. And on the Medicaid side, when we sort of try to isolate what their cost is, it's about $65 million. And again, that's because we think we're serving a population that's a bit sicker. Fortunately, Alliance with reduced some of their pressure by offsetting the increases in Medicaid on the local side. Frankly, because of the moratorium where people cannot get back in if they leave. And one of the things that, one of the phenomena that we'll try to combat is the lower renewal rate. I get emails, not every day, but I get emails from providers who are asking about reinstating a beneficiary. And I might say, well, are they over the income level? And they say, no. I said, well, why do we need to reinstate them? They should already be in. And it turns out that they hadn't renewed in time. Now, if they identify their problem within I think it's the 90-day period, we don't have an issue. We can get them on. But if they come after the period, their re-enrollment and period expires, then it becomes more challenging. And I would be violating, I guess, local regulations and law if I said, yeah, you're outside of your renewal window, but we'll get you back in. We did that a little bit early in the process. I forgot the reason why, how we justified it. Eugene can explain it. But we helped a couple of beneficiaries who were in that spot. But that option is not available to us now. Those two things, the moratorium and the failure to timely renew, is creating savings that is offsetting the pressure we see in the local costs created from Medicaid. I'm not going to spend a lot of time on the administrative budget, except to say it's on the next page, on slide 10, except to say that, the biggest challenge, but we had to fund the loss of the gap created by the federal government's refusal to fully fund DCAS. And also we have grants to Healthy DC of over $10 million for the dental and vision benefit. Those things are driving the change you see or the increase you see in our administrative costs. I would now quickly take you to slide 12, which lists, not that one, maybe yeah, that looks like the one. No, that's 13. There you go, yeah. I asked Melanie to fix the numbers last night, but apparently she did not listen to me. Are y'all numbers incorrect? So our budget, despite the tough budget times, our budget contains multiple key investments. And we mentioned the mayor's effort to sustain eligibility for Medicaid and Alliance. She did so, and that's costing on a local value roughly $125 million by sustaining those eligibility levels. We extended the benefits for Alliance, and that's $4 million, and we extended benefits in the same way for those in the Healthy DC plans, $5.7 million. There is a reserve from that's in our budget for Cedar Hill. The contract requires that that reserve fund be funded up to $25 million. And when that happens, we can stop putting money in. There are rules about whether and how they can draw their money out. And if they don't use all of it by a certain date, then the balance reverts to the district. My hope is that Cedar Hill will begin to at least break even or show a profit. And this reserve fund will be returned to the city. We know they're going to use the first $5 million because of the substantial losses they had. And with the DCAS support is mentioned as well as an investment. In terms of reductions, I think, with the exception of the decision that we had to make to eliminate payments for teaching hospitals on GME side, the DME side, which was 14.9 million. The other reductions are pretty minimal. We did save 1.6 by expanding the preferred drug list, and Melissa and her folks can explain how that works and how we recoup 1.6 by basically covering managed care and fee-for-service with a streamlined preferred drug list program. We also have prospectively reduced the payments, or will prospectively reduce the payments for managed care, for our 3 managed care programs by about $5 million, forcing them to meet the efficiencies that we expect them to meet with respect to hospital readmissions within 30 days, limited use of the emergency room for low acuity problems, and the third one always escapes me. Oh, the avoidable hospital admissions. I will say that I got a notice from my insurance company to tell me how to avoid hospitals. So I'm wondering if if Medicaid beneficiaries who are frequently using hospitals get those same kind of notices from our health plans. They should. Although in my case, my insurance company was off base. I didn't use the hospital inappropriately. And we had a small reduction in payments for empty beds. And specifically, we reduced the number of bed hold days in ICFs, which we pay for. It is a unique concept that has always, since I first became acquainted with Medicaid, that has always befuddled me. But my experts tell me that it is something that we need to do. But in this case, we had to, we saved $134,000. I now want to go to slide 15. And I'm not going to spend a lot of time on it other than to say, and if you have questions, we can certainly dive into this in more detail. That we have, we've made significant progress in getting the waiver approved for the state-directed payments. We've made several payments for fiscal year 25, totaling over $442 million. CMS has approved 485, and we anticipate making one final payment in the closeout of fiscal year 25. We'll make that payment in May or June of 26. We have submitted all of the documents to renew it for 26. We responded timely, thanks to Eugene, with multiple questions from CMS. And in 26, hospitals will do very well. They'll get not a net number, but the state-directed payment will increase by $658 million. 27 is going to go down because of some technical changes that the federal government made to the provider tax. And so they will revert to a level close to 25. And then we are required to start reducing those payments by 10% each year until we hit what is the 100% of Medicare. This will be, if this is not changed at the federal level, hospitals will lose a lot of money because we won't be able to pay them at the current levels they're being paid because of the provider tax. But, it may well be that this is a policy like the disproportionate share program, which I think they've been threatening to eliminate that for how long?
Since 2014.
Since 2014, and we still have the program. So maybe they will rethink the problems that will be created financially for hospitals if they stop these state-directed payments. It will create a significant problem for not just hospitals in DC, but all around the country, especially in rural areas. So maybe they will rethink that when the political heat sort of fades. If you go to the next slide, I know you're probably going to get a lot of calls if you haven't about our cut to DME. This slide shows you what the net inpatient and outpatient revenue from DHCF is to acute care hospitals in fiscal year 25, 26, and 27. The total value of our payments payments that are being made and ones that are projected are at the bottom of each of the bar graphs you see. And if you go to the far right, you will see that we have proposed removing $48 million in total from the fiscal year 27 payment. And if you go to the next slide, you will see which hospitals are hit the hardest. And I think your staff requested and received sort of the history of DME payments. And if you look at that, most hospitals' payments are level across the 4-year, 5-year period the 5-year look back that you requested. The exception being Washington Hospital Center. They got a pretty significant jump, I think in the 3rd or 4th year of the 5-year period that we looked at. And consequently, they're taking a big hit. I frankly am a little concerned about some of the challenges that particular hospital is facing. They have, because of the shift in their payer mix, they're seeing a lot more Medicaid patients than they have historically. And so they're getting squeezed a bit. And I've talked to Ken Salmon and Jackie Bowens about the issue. And we worry, I tell people all the time, I'm a big fan of hospitals. I think people dismiss unfairly their importance to a community and the work that they do to keep people healthy or to bring people back to health. And I'm concerned about all of our hospitals, but when I look at the dynamics that are going on at Washington Hospital Center, it makes me a little nervous that if we can't find a way forward to help them, they are sort of the anchor for the whole system in terms of volume, with GW being close second, and of course Children's has a niche population that make them very important as well. So the last thing you want is the hospital or hospitals where everybody goes to be stressed to a point where it affects the delivery of service. And I think that's something that we're going to have to pay closer attention to in the very near future. But you can't spend money you don't have. And so when we got to the end of the budget process, we were looking at, do we not fund childless adults and save $100 million, but in the process take $1 billion out of the healthcare system? Or do we do something like take money from GME and then you only have to find $50 more million to balance your budget? We chose the latter, obviously, because we correctly believe that if we had not funded childless adults, we could have crippled the healthcare system in this city, because you take $1 billion out of any system, it's going to have a tremendous effect. One of the graphs that we always show whenever we have the chance, because it's this graph on slide 19, it shows you the reliance in this city on Medicaid, and to a certain degree, alliance. 41% of the people in this city rely on DHCF for healthcare coverage. There have been times in the past, certainly around the pandemic, when that number was 50%. It's half of the city. Now it's 41%. So, like I tell people all the time, if you could randomly line up every resident in this city and walked and touched them, 4 of every 10 people you touch would be on Medicaid or Alliance. That's a lot for a system to bear. We track enrollment levels closely because of their budget implications, obviously. And as you can see on slide 20, after some declines during the time before the pandemic, then a rapid increase during the pandemic, and just shortly after, and then a slight decline, we believe the numbers are beginning to increase again for Medicaid, and that will have cost implications. Slide 21, I think, is an important slide because it shows you that when you look at the 3 major health plans, they have a high percentage of members with chronic conditions, and we give them $52 million annually to provide case management services. And probably only one health plan does it well. I don't think any of them are compliant with their contract that says 3% of the population, but 2 who are not compliant are spending way over what they are required to expend on medical expenses, one plan that's not compliant is spending substantially under what is required by both the federal government and DHCF. Now, what does this mean when you say they are struggling with case management? If you go to the next slide, you know, the health plans, by our estimate, of our actuaries' estimate, is paying about $57 million a year more than they have to. And if they had better care management. If you look at the last group of bars, the total, the 57 million, there's 57 million for, that includes avoidable hospital admissions, hospital readmissions, and the low acuity use of the ER. We think these are things that the health plan should make a more concerted effort to make sure that the city is not spending money that we shouldn't have to spend if this care was better managed. But I will be frank, the drift in managed care is toward public health plans. And I have seen a rather disturbing emphasis on let's make money. Let's see how we can make money, to the point that some have even asked, can they basically not hire, can they cut their care management staff? You're not even meeting the threshold, and you want to cut the staff, and it's all because you want to feed the bottom line. I think managed care, the more and more we see publicly owned health plans, the more difficult it's going to be to get them to focus on things that cost a lot of money and hit their bottom line, but it's good for the city and good for the beneficiaries. If you look at it on a percentage basis, the next slide shows you that to avoid, so this avoidable spending amounts to about 15% of managed care spending on emergency room and inpatient care. So 15% of what we spend on emergency room and inpatient care is probably avoidable if we had more aggressive care management from our health plans. So I think, and I'll close by saying this, I think the time has come to rethink how Medicaid case management and care coordination is delivered. We are now seeing enrollment growth among higher cost older adults and beneficiaries, many with chronic diseases, and this will absolutely test the Medicaid program's ability to deliver access to quality care in a model of effective case management. We are pursuing this through our current model with a heavy reliance on managed care, and more recently the PACE program, which frankly neither have produced the results that we completely anticipated. And I think there's scant evidence to support the view that health plans are successfully managing the care for a significant number of beneficiaries. And I don't mean to imply that this is easy. It is very difficult because it's an opt-in process. You have to get the beneficiaries to agree to be managed. But as I tell the health plans, if it were easy, we would do it ourselves and save $52 million a year. So the lack of efficacy that we see with this approach is frustrating for that amount. We're spending $52 million a year. And I think one of the possible solutions is to try to move case management and care management on the ground with the providers who are delivering the care. So I've asked my team and representatives from the FQHCs to sort of reimagine how we might better organize care and case management for Medicaid, possibly moving this function and the funding from the MCOs and locating those activities within the federally qualified health centers. As we think through these issues, my team and I will be sure to keep you and your staff apprised of any developments in our thinking. And that, Madam Chair, ends my testimony for this morning. Very quick, as you see.
Director Turnage, because I know this is your last go after such a distinguished career, and I feel like you wanted to set a record here. And so I think you did what you desired. Okay. All right, let's get into some of these questions. Okay, so we've talked about the Medicaid Management Information System before, MMIS. As I understand it, an update is required, or an update/upgrade is required by the Centers for Medicaid and Medicaid Services to happen every 5 years. Last I spoke to your staff, CMS had not yet approved our upgrade. What's the status currently?
I think, is Don here? What we typically do, and Melissa can pick it up, once we get to a point where we invite CMS in and they test the system, and then we show them the results of our efforts, and then they decide whether or not they're going to approve it. I don't know if we reached that point yet.
Sure, no, I think we typically have a 12 to 18-month period for what's called certification, and that's that final approval. But that isn't the first touch point we have with CMS with the implementation of an MMIS. Like they were, I can't remember if it was virtual or on site, but in February, where our team, along with our vendor Gainwell, presented all the facets of the system to CMS and got the initial go-ahead to go live March 2nd. So it's an ongoing process, and we can update you if you'd like as we go along.
Okay. The provider data management system, which assists with enrollment and re-enrollment of Medicaid providers, is one module of MMIS. Director, as you recall, we held a hearing in March around centralizing Medicaid credentialing within healthcare finance as a way to streamline it, so that providers don't have to go to each of the MCOs and the delays that are associated with that. Now, I understand that enrollment and credentialing are two different processes, but how could potentially healthcare finance use this opportunity for recertification to expand the scope of the provider data management system to give it authority to centralize credentialing as well?
Sure. Well, initially, we would need to alter the request for proposal to be inclusive of credentialing activities, in addition and above to the typical enrollment expectations. And in order to do that, we would also have to have the appropriate funding to support that.
Okay, but no one has told us how much it costs yet.
I know we looked at initial estimates. What I do know, it was an ad that I think was a few $1 million total. But we can look back and see what the latest update is on that. And what we did initially was talk to our current vendor and a couple other states, I believe, to talk through that. And then we also had some work done by our actuary to see if any of those costs would be, I was hoping they could be wholly offset by reducing the administrative costs that the managed care plans currently expend on credentialing. It's not a 1-for-1, so it would still be a cost out of the district's pocket if we were to assume centralized credentialing, but we can follow up with that.
Okay. You noted in your testimony, Director, that healthcare finance transferred $5 million for improvements or at Cedar Hill Medical Center. I don't say improvements, but you transferred it to the fund as agreed to by the operating agreement. Are there specific terms to it? Meaning, is the hospital required to use the funding for something specific?
No, it is tied to their financial performance. It was put in recognition of the fact when you start a new hospital, it is almost accepted that first 2 or 3 years you're going to lose money.
Okay.
The only question is how much. And so we put in it as a buffer. In any year that they don't break even, then they can draw on the fund for the amount that's in the fund or $5 million, whichever is it greater or less? Whichever is greater.
Okay. How long? I think I remember this. I think it's 10 years.
10 years, I believe.
Okay.
Yeah.
After our last hearing on Cedar Hill, roundtable, there's a report that is due. There was supposed to be a meeting that was had, and then the public is waiting for that report to become public. My understanding, it won't become public until after the meeting is had. So when is the meeting scheduled for, and when can we expect to see the report?
The meeting is on first let me say that UHS has submitted the report.
Okay.
I'm partly the reason that it has not become public yet because I've been out And I did see on the mayor's calendar that there's a meeting scheduled with UHS as required by the operating agreement. I think it's in June. So I would imagine that the report would be public shortly thereafter.
Okay. All right. Respectfully, I'm going to ask that the meeting, even if the meeting doesn't happen in June, I know the mayor's schedule can get sort of sideways, et cetera. But I think there was expectation that we would have had this report in April. So now the idea that it won't get released to the public until June, although from UHS's standpoint, they've done everything that they're supposed to do. I think I have an upcoming meeting with the interim CEO, and I'm not sure what we're going to be discussing, because I guess we'll be discussing a report I haven't seen. Unclear, but the point still stands. If you guys can try.
So your request is that the report be released sooner. Is this what, I think is what I'm hearing, correct?
I'm sorry?
So your request is that the report be released sooner? And just.
Yeah, well, if for whatever reason, the meeting with UHS gets pulled down to August, please don't wait until August to release the report. That's my,
Yeah,
you know what I'm saying? Like,
Sure.
the meetings can change, but
Sure.
this is something that we have been anticipating for a while in terms of our oversight work. Okay, I want to talk about direct medical education. You sort of explained some of the rationale for eliminating it, which is simply budgetary pieces, but what conversations, if any, have your staff or you had with our teaching hospitals about this, who's considering it's May and the end of a school year, like their budgets are already set for next school year or the next residency cycle, which would have anticipated this funding?
Yeah, well, there's a limit to how much we can share with any provider prior to the mayor's submission of their budget. So there was not a lot of discussion with them prior to that. Once we announced, we had a meeting with the Hospital Association 2 weeks ago, whenever it was, 3 weeks ago, where we presented this information. And of course, some expressed alarm. We are certainly willing to have any conversations that they would like to have on the impact. But at the end of the day, unless we have more money, there's not much we can do. But again, I am sort of on a larger issue. I am having discussions with, at least one hospital about some of their challenges, but it wasn't directly tied to the DME cut, although that's a part of it. So yeah, I mean, the hospitals are really concerned. But we can't take on a item that we don't have the dollars to pay for.
Okay, and we heard from testimony from multiple witnesses concerned about what this will mean for residents' salaries and for hospitals across the district. You spoke very fondly of hospitals, but our teaching hospitals our residents are, I would say, the lifeline of our hospital system here in the district, and they already get paid below poverty wages, in my opinion, in sort of the name of, well, you're getting an education out of it, even though they're working, 13, 14-hour shifts in some cases. I feel like I know that trade-offs had to have been made, but it also in a situation where we already have challenges with the healthcare workforce, this is like another hit.
Well, it would have been a bigger hit if we had cut childless adults, because they would have lost, the hospital system would have lost, or the healthcare system would have lost $1 billion. And I'm not suggesting that hospitals are flush, but the state-directed payments do help considerably. And, hopefully this will be a temporary challenge that can be revisited if, revenues return in future years. So I sort of view it as a year-by-year issue that we can certainly, or somebody can certainly take up when the revenue picture is more, maybe changes for the positive, hopefully. But, that's a big hope now in the district because of the cost structure for the city and the revenue patterns over time.
Well, I was glad that in your testimony, you sort of name, like, I'm concerned about Howard. Because this on top of Dish, that is like a double whammy.
Yeah, Howard owes us, how much is this? 30 million? Howard owes us about $30 million for overpayment on Dish. So we didn't cut their Dish. We paid them more than they could justify. So now they have to pay us back 30 million. Now, we can, if the mayor decides she wants to forgive the local share of that, she can do it, but that money, their overpayments have to be first redistributed to other hospitals who did not hit their Dish ceiling.
Right.
And then if anything's left, the mayor can say, you know, okay, Howard, you don't have to worry about paying us back to local. But if somebody doesn't pay back the federal, then they will get it from the district. And that's a challenge. So yeah, I worry about Howard as well for a number of reasons, not the least of which is the money they owe us in Dish.
How did we get to a point of overpaying by 30 million?
Well, Darren is our Dish expert. He does a tremendous job. He can explain the process to you. But in essence, they fill out a survey to tell us how much we owe them and we pay them, and then there's a reconciliation on the back end. But Darren can give you the more specific details.
Like $1 million or $2 million, okay. 30, that's a lot.
Yes, and I don't know that I can speak to the details of that right here, right now, but I can certainly follow up. But what Director Turner said is accurate. We send essentially surveys to the hospitals. They complete based on, you know, their best information. We use that information. We essentially rely on their attestations that the information is accurate, and that's for all the hospitals. And that's the basis of our allocation of Dish funds. And then as federally required, we come behind 3 years later. We have a contract with an audit firm. The audit firm audits all of the hospitals who receive Dish, looking, you know, at their allowed cost versus, you know, the payments, and then they do the calculations. So that's where it landed for Howard for fiscal year 22.
Okay. We
And I can follow up with you.
Yes,
if you
let's
want more
unpack that
specifics.
on another day. Okay, I want to ask about, you mentioned in your testimony, a more streamlined preferred drug list for Medicaid MCOs and fee-for-service, which should capture, around $1.6 million in local savings. Will these drug lists be made publicly available? Or like, how do you all communicate this info to both patients and providers?
Sure. I'll give the initial, and then if Dr. LeBird wants to add anything on. But yeah, our preferred drug list, it will be made available. What we're doing is creating a single preferred drug list. Currently, we have one for the fee-for-service program, and each of our managed care plans has their own preferred drug list. So we have six across
each
the board. Yes.
Oh, I see.
And so the idea of going to a single PDL, my personal interest in this is last time we did a significant managed care transition. One of the biggest complaints we hear from residents is moving, when they must move plans, sometimes their prescriptions that they're accustomed to change based on the new plan's PDL. So going to a single PDL allows a uniform preferred drug list across our program. We believe it will also help providers in terms of they'll know what's available to Medicaid beneficiaries. It helps our residents knowing what's available to them in the program. And as the deputy mayor suggested or presented in the testimony, does produce some savings to the district.
Okay. I was pleased to see the $5.7 million increase for the dental and vision coverage for the Healthy DC plan, and $3.9 million for dental and vision for the Alliance program. We've discussed this before, but hopefully a lot more people will choose to continue to invest in part of their oral health and their eye health as part of this. My understanding from Health Benefit Exchange Authority is that this benefit can't start until the start of plan year 2027. So that would be in January.
Yeah, I vaguely recall that to be correct, yes.
So I guess two questions that I have. The 5.7 and the 3.9 million, is that enough budget to carry through the 12 months of 2027? Because this is the weird part, right? Like we budget on the fiscal year, but this would need to cover across the plan year, which is that side.
Yeah, I think it is 9 months, April, you know.
So, excuse me, April Grady, Interim Senior Deputy Director of Finance, the one with the big feet. The Alliance estimate for dental and vision is for 12 months of the fiscal year. So
Okay.
beginning in the last quarter of calendar 26, going through the third quarter of calendar 26. For HBX, we'll get back to you, but my understanding is that is a fiscal year 2027 estimate. So that would be the first 9 months of calendar year 2027. And then the financial plan would cover the last quarter of the calendar year for HBX. So
Okay. I just want to make sure that we don't have any gaps because of that. But also, I'm going to say for the public who might be thinking, oh, I can get my dental and vision coverage starting October 1. Unfortunately, it won't start until January 1. All right. Speaking of Alliance, the FY26 supplemental swept the 21 million in the contingency list funding to restore benefits for enrolled Alliance beneficiaries, as well as a $25 million savings in terms of reduced enrollment. So the fact that they was able to find $25 million in savings in fiscal year 26 because of reduced enrollment suggests that we've seen a steep decline in the Alliance numbers. How many people are currently enrolled?
I'm pulling that up right now. But you are correct that we have seen some pretty substantial reductions in enrollment. Part of that is because we did lower the eligibility level for adults from 215 to 138. So part of the sort of big drop that we've seen just over the past year is attributable to that eligibility reduction.
Okay.
For the people who remain, for the adults below 138% of poverty and children up to 324, because we're still consistent with the Medicaid program on children. As Deputy Mayor mentioned earlier, we are seeing lower renewal rates than we have historically. So that is a contributor to any enrollment declines that we've seen in addition to the eligibility change. And then in addition, the moratorium also has an impact because to the extent the adult enrollment moratorium has an impact because to the extent that someone falls off because they don't renew, we don't replace them, right? So this is sort of a twofold contributor to any reductions in enrollment that we're seeing. So I just need to flip to my correct tab for my enrollment.
Okay. While you're looking for that, April, we've requested a variety of different cost estimates that we haven't received yet. So how much it would cost to remove the age moratorium at the current income eligibility of 138, how much it would cost to take the age moratorium back to 26, how much would it cost to restore the program back to 215, XYZ. I marked this budget up next Wednesday and I don't have budget estimates for some of the pretty big things. I can't even tell my colleagues how much it would cost. When will
My
CFO
understanding you will get that today.
today?
Yes, all of those.
Okay.
I would, I haven't seen the estimates yet, and I certainly don't question what Darren and his team do, but I would imagine that is a very difficult estimate to produce for a number of reasons. Particularly if you was saying what would it cost when you take it back up to 215? We'd have to sort of understand how many people would come back to the program if there's no moratorium. You also have to understand if you take it up to 215 and don't adjust Medicaid, then there are a lot of people who are in the exchange who were pushed out of Medicaid and into the exchange, you know, and in a very, you know, careful and systematic way. They'll probably come back to the Alliance because there's no cost on the Alliance, whereas on the exchange, they have cost sharing. So it is a complicated estimate to generate. And if you miss, the consequences could be pretty catastrophic from a budget standpoint.
Okay. I look forward to receiving the estimates today. Okay, last year, healthcare finance was able to absorb the cost of annual recertifications instead of recertifying every 6 months, as well as allowing for recertifications not to happen in person. Can you confirm on the record that the budget that has been proposed is for annual recertifications, not every 6 months?
That's correct.
Okay. And will these recertifications be required to be completed in person?
We have not proposed changes to the Alliance recertification process. I will note just on the Medicaid side, we will go to 6-month recertifications for childless adults starting January 1st, 2027, as required through the One Big Beautiful Bill Act.
Will those be in person? Or they don't specify?
No.
Okay. All right. So it's been about 7 months since we switched the Alliance program from MCO over to a fee-for-service model. Your staff sent in pre-hearing responses that we've been trying to ask questions around like trends, utilization thus far. And there was one area where claims are lower now than they were before the Alliance program changes, and that was around pharmacy. I'm curious, are you all concerned about the reduced pharmacy utilization, or would it be too much to just sort of read into one data point?
I would say we're certainly looking at it to make sure that it reflects appropriate utilization that we expect. And I'd say a few things. One is that we get detailed reporting from Prime, our pharmacy benefit manager, about the types of drugs, and are tracking that very closely. The other thing is we've looked at the pharmacies where the prescriptions are being filled, and I believe you mentioned in the public testimony hearing that we had in the past a number of fills that were happening out of the district, so in Maryland and Virginia. Those have been substantially reduced is what we are seeing in the latest information. So we are going to dig further into this, but at least part of the reduction may be due to folks filling largely here in the district. Last thing I'll say is it's not unexpected or inappropriate for someone to fill outside of the district, for example, if they have a job across the state line, but that is something that we're going to be looking a little more closely at.
Okay. Okay. Healthcare finance anticipates spending about $36 million more in local funds this year because the populations for Medicaid and Alliance have shifted, as you sort of mentioned in your testimony, older. They also have more chronic diseases than the population a few years ago. The Primary Care Association and the Connected Care Network testify that they have data that shows that Alliance beneficiaries who receive care from FQHCs exhibit lower emergency room use and inpatient utilization and had lower overall disease prevalence. Have you guys looked at this data and I guess rather the argument that's being presented by
we had
DCPCA?
a very productive and long meeting with them. I think there's study, I mean, it's a good study. I think it has some methodological challenges that they can't overcome. But I wouldn't say that the results are completely off because of those challenges. And basically the challenge is the population they have is lower risk than the group that they compare them to. So they try to adjust for that statistically, which you can do to a certain extent, but not completely. And so you could be overestimating the impact for your program group because they come in with a lower risk, and so they're less likely to go to the emergency room in the hospital. And so if you're comparing them to people who are more likely to go, you really have to make a sound adjustment for that difference. They made a good effort at it, and it's a very well done study. And I think it has some merit, and it's something that one of the reasons, frankly, that we are, thinking internally about moving case management out of managed care and into the FQHCs.
Okay. It's interesting in your testimony and the slides you presented, those last few slides where you were sort of comparing the MCOs on various trends. I think it was around readmission rates, unnecessary emergency hospitalization visits. And I think you noted that like 15% of our spend is on emergency room visits. And I would just note that it kind of goes back to something that I wrote you and UHS separately around, which was this plan to open a new freestanding emergency department in Ward 7. If we are spending all of this money on emergency rooms now, opening another emergency room in an area where they desperately need urgent care is only going to cost the district more money on the back end, I think, from a Medicaid standpoint.
Well, a slight correction. The 15% represents the avoidable spend on emergency rooms and inpatient care. So it's not all emergency room, but emergency room is a key component. To your point, I think what UHS would say is it's not either or with this freestanding emergency room, that they will have a triage system with sort of an urgent care system where you basically come in and they evaluate you, and if this is an urgent care need, they will treat it as such, and you won't get to the emergency room. So it is a more expansive project than just an urgent care facility, and hopefully, if they do it correctly, they could actually divert people from the emergency room with the upfront evaluation of whether or not they even need to be there. Hopefully.
We'll see. You won't be here for that part.
You're running me out of here pretty quick.
I'm not. So know that I think we just approved the land disposition for Fletcher Johnson like 2 seconds ago. So, I don't confident believe, and maybe I'm wrong, that anybody's breaking ground on any freestanding emergency department this calendar year.
No, it won't be this calendar year, I think.
Right then.
I think. Yeah, it won't be this calendar year.
Unless you are saying you're staying longer.
I don't, that's out of my control, obviously.
All right. Several witnesses testified this year and last year asking to delegate authority for recertifications to FQHCs. What's the agency's position on delegated authority?
So recertification to the FQHCs?
I don't think delegated, it is allowing the presumptive eligibility, I
Oh.
believe is the request, right? Yes, has been the request is on the presumptive eligibility side. I don't think it's something that,
Go ahead, I'm sorry.
okay.
No, you go ahead.
I was like, yo, it's on.
I'm sorry.
I hope you like what I'm going to say. I don't think we have like a philosophical opposition to it. It has mostly been the ability and the capacity to support the FQs and others and actually being able to effectuate it for us. It does mean a state plan amendment, things like that, and making sure that there's the training for the presumptive eligibility and all the systems changes as well, et cetera. So it's more process than anything.
Okay. There was a story that was shared about an Alliance beneficiary who is in the hospital. They were treated. They now no longer need that acute level of care, but they can't be discharged yet. Partly because the appropriate setting would be either a skilled nursing facility or having home health care to have an aide to help with those works. And those are two services that Alliance no longer covers costs for. Considering how healthcare finance pays for hospital inpatient claims and other outpatient care, what conversations are happening to ensure that beneficiaries are receiving the highest value care at the lowest cost possible for the district? You turned your mic off.
Relative to that circumstance, we always try to, on a case-by-case basis, resolve it in a way that eliminates the inpatient care, the unneeded inpatient care. But after a while, that cost falls on the hospital because they can't bill. If the person is in an acute care bed, but they're not getting services, then the hospital can't bill anybody. So we want to help the hospitals by getting people out of those beds because they also hurting throughput, get them out of those beds, eliminate the losses for the hospitals and move them into an appropriate level of care. It is a very difficult thing to do. I know Melissa has worked with several cases over the years. But systematically, there's not a lot we can do systematically beyond what we already do. And when you have not the rare patient, but the patient that falls into that gap where they don't have long-term care for whatever reason, and they don't have a home situation where they can be returned to a home and receive care, then it's a struggle. We sort of put our creative minds together and do the best that we can. But fortunately, I don't know, Melissa, how many of those cases have you dealt with recently?
I think probably 6 or fewer. I'm going to look to Dr. LaBird. Does that sound okay? Because she handles a lot of them, probably about 6 or so. And they are intensive cases, oftentimes without an option for someone to return home. And then this question of whether they have the benefits afforded to them to support that care as well. We did, one of the efforts we put forward through our 1115 waiver was the option or the proposal to bring in respite care, medical respite. So for exactly those folks who no longer meet that hospital level of care, but they can't be discharged safely home or elsewhere, that would be one option. That has like a bit of a housing component to it that is unclear. I'm not expecting that's probably likely to go through with our waiver approval, but there are some medical components that we're still exploring to see if that's an option long-term. But I mean, to the earlier points about the aging population and on the different concerns, I mean, this is going to be an ongoing issue, and it's the deputy mayor said, and it ties in, I think, to the earlier discussion of housing. It's an extraordinarily challenging issue.
Yeah. I was like, I know of one organization that is trying to set up medical respite beds at the East Street site. They're not ready to go yet. And even still, I don't think that it's supposed to be temporary. So I don't necessarily think that that's going to address the needs.
I do think that's one of the concerns. Like, I think it helps you for probably about up to, I know when we were talking about up to 6 months, but then the question is after that 6-month period. Right. So are you kicking the can, the problem's kind of down the road? It makes the initial kind of, ensuring that we're utilizing hospital beds for the appropriate use, which is ideal, but it doesn't completely ameliorate the issue or make it go away.
Now, Deputy Mayor, you brought this up in your testimony, but I'm also asking on behalf of some of the advocates who brought this concern, which is that there are some Alliance beneficiaries who maintain their coverage post the October 1 change, but for some reason did not renew within the 90-day grace period and are now trying to renew their coverage, but are being blocked due to the moratorium. What options, if any, do these individuals have?
Legal options?
I'm sorry?
So legal options?
Yeah, legal. Nobody,
yeah.
yes, legal. We're on the record. Yes, legal options.
It's a very hard thing. I will tell you, when I get those cases, and Eugene and Melissa can attest, I push real hard to try to get them back into care. But we are, once we get past the gray area, that we had a large gray area during the early execution of the policy. Once we get past the gray area and it is clear that the person did not renew in time and that the moratorium has now is therefore in effect, it's hard to give them a benefit or give them access to the benefit. I mean, I will recall to tell you how difficult this can be. I recall a case where we were dealing with a woman who had cancer, and she was not eligible. This wasn't Alliance, it was Medicaid. And so I went all the way to the Attorney General to try to get her, no, she needed a lung transplant. And we even got her to the hospital, and they said her Medicaid wasn't active and she was no longer eligible. So I went to the AG and they sent back a ruling that said you cannot specify benefit for a single person or individual case that is outside of the policy, outside of the statute and regulation. So You know, we look hard, we don't give up, but it becomes more difficult. So I go immediately to Eugene and Melissa and say, how can we help this person? And Dr. LeBird, sometimes we found a way and sometimes it's very difficult to find a way.
Yeah. Not that this is on a list or has been an ask, but how much would it cost to extend the grace period beyond 90 days?
I have to leave that one for Darren.
I mean, this is a new one. I know I haven't asked this question before.
We have not looked at that question, so we would have to do some research and get back to you.
Okay. And I will say, we had this conversation last week with Mila Kaufman too, right? A 90-day grace period is pretty standard.
Yeah.
This is from my time for the PSA for any of you 2,300 people who have not responded to the Healthy DC emails. Please submit your recertification documents because you are at the edge of your 90-day grace
Right.
period and will lose your healthcare. Okay.
Yeah.
Yeah, policies are policies, right? And this is the part that is really difficult. People desire and / want the government to continue to be this sort of very nimble, non one size fits all, but a policy is a policy and a statute is a statute.
Yeah. And Eugene can remember how we were able to justify it when we did it early on. You want to come up and, do you remember that?
No, I mean, that's okay.
Okay.
That's fine. Yeah.
Well, I was just gonna say, early
Amplify
on,
our gray areas from before.
I believe early on, we were within the grace period for everybody. So during that transition period, we were mostly able to get folks in. So I think that was the largest reason, how we were able to extend the coverage.
Okay. With the changes in eligibility to emergency Medicaid, as well as the federal healthcare changes limiting access to affordable coverage, we're definitely going to see a rise in uncompensated care. That's probably going to arise. How does this budget, if at all, set up a cushion for that might arise for hospitals?
It does not, but I'll let April talk about the emergency care, the emergency Medicaid calculus. You know, the benefit there is DISH, but hospitals have to, first of all, has to be a DISH hospital, and the hospitals that this will fall on typically, they aren't DISH hospitals. So that would require federal change to what is a DISH hospital. I think it's, you know, I've told Ken Salmon this at Mestre. I said, I don't, to me, it's unfair that Washington Hospital Center is not a DISH hospital because they serve such a large number of Medicaid beneficiaries. Now, it's a smaller portion of their total book of business, but in terms of the impact in this city, it is huge. And we're giving money, we're not even using all of our DISH money because other hospitals don't have the amount of uncompensated care to draw it down. So we don't use it. And meanwhile, you have a hospital that is eating a large loss on the uninsured, and they can't access DISH. So it's a policy change that has to occur. But in this climate, I don't know that it will.
The one thing I would highlight in this budget where it supports kind of limiting uncompensated care as much as possible is the continued support for the eligibility levels across Medicaid and Alliance at the current 138. We've talked today a lot about, you know, if we had cut childless adults out of the Medicaid program, that also would have eliminated emergency Medicaid coverage for anyone who would fall in a childless adult category, non-US citizen. So, you know, it is maintaining the status quo, and there are some, you know, couple difficult decisions that were made in order to achieve the savings that we needed, but that investment and commitment to the current eligibility levels really is a strong commitment to trying to minimize uncompensated care as much as possible.
Okay.
The only thing I would like to add on top of that is you had asked about some of the policy options that the committee is considering for removing the moratorium or changing different aspects of eligibility. To the extent that Alliance were to go back to coverage above 138% of poverty, so covering the 139 to 215 that used to be part of the program, I just want to clarify that there is not emergency Medicaid available for that increment of the population. population. So to the extent that they have inpatient emergency costs, that would be at 100% local, because we have emergency Medicaid federal funding for the below 138, but that would be full district cost.
Got that. Okay. She's feverishly typing over here. I will say that this is rhetorical, but mainly for the public, right? I understand and sort of our desires to have parity amongst the Medicaid and Alliance populations, because that has always been our line. However, individuals who are above 138 have a new option that is not available to you if you are not eligible for certain reasons. You know what I'm saying? Like, right? So like, I know we're always trying to match, but I think the circumstances are very different from a Medicaid beneficiary and an Alliance beneficiary. And I just want to name that.
Yeah. So
You have an option if you have Medicaid above 138. You don't have that option above 138 if you're on Alliance.
that is true, but then you would have to have language that prevented those people from coming back to the Alliance. Because they will come back, because it's cheaper.
But a healthy DC person choosing to switch to the Alliance program?
Yes, because they don't have any cost sharing in Alliance, like you pay for everything. And so they would avoid all cost sharing. And that means something to somebody at that income level. So unless you have language that says, I don't know how you would word it, but you would have to specifically,
I mean, you'd have to limit eligibility to Alliance if you are eligible, if you are meet the criteria for Medicaid. Well, I don't know.
Yeah,
you know
what you would have to do is say that we're going above 138, but only if you are an undocumented, or only if you're not lawfully present. If you're lawfully present, you can't come back to Alliance, even though we're taking it up to 250% part. And there will be some significant tension around that type of policy.
Or lawfully present, considering HR1 remove the eligibility of people who are lawfully present to even be a part of Healthy DC. We got like what, 845 of those?
Yeah.
845 individuals who are here lawfully present, but because of changes in HR1 are going to lose their health care in January.
Right. So, and those people would come back to Alliance too then. So that number would grow. Well, I mean, if she lifted the moratorium.
Okay. I want to ask really quickly about state directed payments. Have you all had conversations with the Hospital Association to determine how, for the fiscal year 2025 bucket, how the money will be spent for the various priorities? And just to remind you, the topics identified in FY25, when we did this language through the BSA, enhanced care coordination, addressing social determinants of health, improving nutrition access, strengthening maternal and child health outcomes, supporting long-term care discharge and transitions, and expanding substance use services, and investing in workforce development pipelines.
You know, I think, a lot of what they do, a lot of them do that as a matter of course, not everything you mentioned, but a lot of those things you mentioned are done as a matter of course. Now, Melissa, I don't know if you had a conversation.
No, we have an internal one set up sometime within the next couple of weeks, I believe, and then we'll begin that outreach. The focus really has been getting on to initially the initial approval by the federal government, which took an extraordinarily long time, and then moving into the second and third rounds for the 26 and 27 requests. So it's been more focused on that piece and not as much on the other, but that's on our plate for now.
Okay. I mean, I want to make sure that like there was an agreement here, and I want to make sure that the investments happen. So who is this a healthcare finance, you all monitoring to make sure? Because, we get into additional fiscal year, so we're moving into FY27. People forget, oh, wait, there's still some things from FY25 we got to wrap up.
We can monitor and cajole, but I don't think the money comes with strings. They pay the tax, they get the revenue, and then we can try to, and I don't think the effort would be that heavy of a lift, because I think they want to do a lot of these things anyway.
Sure, but legally they would need to demonstrate that they spent the money in some of these buckets, no? You don't get to just get the
I
money
don't-
and then not say what you did with it.
I don't know if there's language, it may well be.
Yeah,
There's-
it was in the Budget Support Act in fiscal year
because
20.
I didn't know the language mandated that. I thought the language was, sort of guidance. But I have to go back and look. I haven't looked at it in a while. But if the language is there and it says this is what you must do, then we will certainly have conversations with them and we can easily monitor, how they're spending them. Not easily, but we can monitor how they're spending them. Hospitals are
Right.
very complex entities and their books are difficult to decipher, but we'll take this officer take a look at it.
Okay, I was just saying, when we did this in 25, I guess, yeah, 25, it was the understanding that the hospitals were getting some money, the city was getting some money out of it, and that there would be some monies that are directed towards priority areas. We don't specifically say, and you must do X program, but we did say these areas did need to be hit. And so that's what I'm saying is like, are we checking to make sure that everybody's holding up their end of the bargain?
You're correct. You've jogged my memory. There was, I remember talking to Jackie about that extensively. Yes. Those things will be easily monitored. And Jackie will sort of help us because this is something she has championed.
Right.
So I thought you were talking about the entire pot of money for,
No.
okay.
But like,
Understood.
when we said yes to this, there was like, okay, we're gonna do an enhanced
Yes.
focus on these priority areas, and I want to make sure that we're delivering.
I
on that.
remember well now. You're correct.
Okay, in terms of the changes that HR1, I'm trying to use my words wisely. The changes that HR1 is requiring, do we have to resubmit something to CMS for 27?
Take that.
We've submitted, you're welcome.
Good morning,
Good
Eugene.
afternoon.
Oh, good afternoon, Eugene.
Eugene Sims, I'm the Policy Director at Department of Healthcare Finance. So we've heard from CMS, they have not been exactly clear about what we need to submit to, as it relates to the lower threshold for FY27. We know we'll need to submit a updated state plan template. We expect rulemaking from them about how they're going to expect us to implement HR1 changes, I think in the near term, maybe June-ish. But we know we'll have to submit the updated tax demonstration. We know we have to submit the updated state-directed payment template. And if there's additional things that will be required, we have yet to hear those from CMS, but we know they're working on federal regulations.
Okay. All right, thank you.
Okay.
Okay, final two areas, work requirements and DCAS. And then we can get out of here and everybody go have a good lunch. Okay, you all, I believe, received about 2.5 million from the feds to implement changes in terms of the work requirements. How are you all allocating that funding?
We expect that most of that will be within DCAS, and we are expected to spend that in fiscal 26. So it would be separate from any fiscal 27 conversations about funding.
Is the implementation grant funding, I don't even call it a grant, but was it only one time?
It is one time.
Yeah, federal government giving everybody, all the states, a multi-million-dollar mandate and only give you pennies one time.
Yeah.
All right. Is the CMS guidance on implementation finalized yet?
No, the interim final rule is technically due by June 1st to be published. We do know it's been conveyed to the Office of Management and Budget, which is usually the last step in the clearance process before publication.
Okay. All right, we talked a little bit about some of these questions earlier, Director, so just give me a minute. I'm trying to. Well, I guess I actually have this question. Do you guys know how many families are overlapped in Medicaid and SNAP?
We do not currently, but we have a data use agreement working through the gears right now to be able to do that analysis.
Okay, all right. It's like, I know on the SNAP side that if the requirements were in effect today, I've got over 17,000 residents who would not be in compliance. So it would be nice to know what that overlap is on both. Okay, so we've heard some feedback from community partners with a request for certain conditions to fit under the definition of quote unquote medically frail. The medically frail definition for work requirements, is that a local definition or is it something from the feds?
The federal government is or has provided guidance rooted in two existing definitions of medical frailty. I think where we have the local flexibility is when we look at which diagnosis or billing codes fall within those definitions. And that is what we are focused on. And that is what will really kind of flush out what medical frailty looks like for the district.
Okay. For the states who have gone first, are we going to be bound by their definitions / implementation?
That is not expected at this time, but without final guidance, anything is possible. But no, I'm not expecting that. We
Okay.
haven't gotten a standardized protocol from CMS.
Okay.
What is likely to happen, there will be significant variation in how medical frail is defined to a point where CMS 2 or 3 years out will come up with a standard definition. That's what I think will happen.
I don't know. No Child Left Behind, we told every state that every child had to be proficient, and then we allowed every state to define proficient for itself. Until we decided we actually don't care about children being left behind, and they basically repealed the legislation. So.
Well, they have a different incentive.
You have to.
Well, my hope is it's not based on a goodwill at the federal level. It's based on their incentives. I can see.
Which are financial in nature.
Yeah, absolutely.
Okay. DCAS. That's a funny little thing that has cost us 3 football stadiums over the years.
But it works.
What's that?
It works.
It works.
It works well.
Last time you talked to some of the staff over at Department of Human Services about the operational workings of.
We have a running disagreement about what the problem is, so I don't talk to them too much.
You guys are the ones who have the contract to build out the system. They are the ones who have the workers who have to use it every day, but you're gonna have an operational disagreement?
But let me remind the history. We gave them complete control of the project and the system building when it started. They wanted all of these programs in. It's very complex and it kind of imploded. And so the then city administrator said, take it back, DHCF. And we did. And we got a system out of it. Now, I think there are some things that have to be done to make it a little bit easier to use, but those things are underway.
Okay. How are we ensuring that there's no duplicative funding to make the changes to DCAS, giving multiple funding streams that are now allotted for the program? So you have capital enhancements, you have operating enhancements, and now you have federal grants.
I think the high level response, and I'm getting into stuff that others should know better about, but we cost allocate everything. We have a cost allocation plan for DCAS. And so you have based on the number of folks that you're in Medicaid or SNAP or TANF, and it's marked out by percentages based on the program, and the cost is allocated appropriately. So that's the really high level way that we track those things.
Okay. Director, I talked to your staff about this, but everybody was like, we got to wait till Wayne comes back to answer the question. So, as you know, we have a bill pending in the council for Medicaid buy-in, the Judith Human Bill for Workers with Disabilities Act. The fiscal impact statement for that calls for $199,000 to do software upgrades for DCAS. I kind of feel like out of the $90 million proposed budget for DCAS, $199,000 is a rounding error, perhaps. Is there also, given that there has been a balance at the end of every fiscal year for the past 7 years in the DCAS line item, we went back and looked. The total local share over the financial plan is $400,000. It's 200,000 in FY27. My question is whether or not healthcare finance can absorb that cost.
If, I haven't looked at the data the way your folks have. Everything you said seems very reasonable. I can certainly talk to my team to see if we can find a way forward with this.
Okay. Hopefully somewhere in the $90 million cost allocation line for DCAS, we could find
These kind of conversations cause Darren to sweat.
$199,000. Darren,
I can feel him tensing up as I was speaking.
I'm just saying. Let's see. $16 million in unspent allotments over the course of the past 7 years. $25 million. It's okay.
Local? No,
Huh? Total.
total,
Yeah,
not local funds.
correct.
Right.
Yes. All of which over 200,000.
Yes, I would point out, however, one cannot match federal funds with federal funds. So having excess federal funds available doesn't mean that funding could be used to match other federal funding in order to accomplish the goal.
I told you we were gonna get him started.
I know. If we could share data, we can share data. I feel very confident that in the local allotment where there's always DCAS money available, that we could find $200,000 together. Okay. Director, is there anything that I haven't asked that you guys want to share for the record?
I won't speak for the team, but I will say there's nothing that you haven't asked that I would like to bring to your attention.
I'm missing a page. We're not done with questions. Sorry. I thought we were done. I'm missing 2 pages.
Uh-oh.
They're on the printer. Okay. All right. Dun, 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 dun. Apologies. Got some maternal health questions. Okay. During public witness testimony, some advocates share concerns that pregnant patients were being denied access to Medicaid coverage because DHS was asking for proof of pregnancy in the application process. Can you confirm for the record the steps that a pregnant person should take when applying for Medicaid coverage through District Direct? What documentation would be needed?
A person does not need to verify their pregnancy. They can say they are pregnant and provide us the expected due date or conception. Yep. And that is sufficient. We understand that sometimes folks get messaging from a service center that contradicts that. We have followed up as recently as last Wednesday on that issue because our stakeholders raised it. It's not the first time it's happened, but it's been several months. My understanding is I think for some of the other social services programs may specifically be TANF, there is a requirement when you're in your 2nd or 3rd trimester. And so we are working with DHS to make sure that the Medicaid policy is clear and distinct for the caseworkers and it's understood that you do not have to show any verification of your pregnancy.
Okay.
For Medicaid.
All right. A few long-term care questions, and then we'll be done for real. Apologies. All right. One of the attachments that Healthcare Finance shared with us in the pre-hearing responses noted that the home health rate study was suspended. Now, I understand from your staff that this was because the vendor did not, or I guess you guys felt like the information that you had at that point was sufficient, and that you didn't need to move forward because you guys were looking towards a bundled rate. What's the timeline expected to implement this?
We are in those discussions right now.
Okay.
It's likely not before 28, not before 28. Everyone's giving the correct head nod for that. But those will have a better timeline probably within the next month or so.
Right. We had a resident who reached out to the committee because her disabled son requires care from one of the healthcare finance contractors. She's been extremely disappointed by the level of responsiveness and care that her son has received. And I won't say on the record what the company name is. I can share this with you guys after the fact, but the contract does appear to be in its third option year. So my question is more around how vendor performance is evaluated each year before you all decide to exercise option years.
I mean, we have a formal process through Office of Contracts and Procurement where we assess on an annual basis. I have not had to do one of those myself in quite some time, so I can't speak to the specific questions. I don't know if anyone on the team can, but we can get back to you on that one. But if we have significant issues throughout the contract period, we have different ways to address those. One, just typical oversight and monitoring. If it escalates to a certain degree, then it's a corrective action plan or other letters of enforcement that we can issue.
Okay, but as you guys receive complaints throughout a contract year, are those being documented in some way such that it gets back to the OCP team? Because not necessarily with your agency, but I can think of other departments where we keep using the same contractor because nobody wrote anything down or shared anything with the OCP contract specialist. So they just assumed that everybody was satisfied with the performance when in fact it was a horrible contractor who probably should be disbarred, but here we are.
For the specific contractor that you're speaking of, I'll follow up with you afterwards.
Okay.
And then I can also follow up just generally on what the practice is unless no, okay, we'll follow up.
All right. There was testimony raised concern around healthcare finances policy proposal to reduce the Medicaid bed hold for immediate care facilities for individuals with intellectual disabilities from 60 days to 18 days. To align with the policy for nursing facilities. Now, your testimony noted that this will result in a mere $134,000 savings for the district, but what was the overall reason for the change? It couldn't have been financial. We didn't get enough out of it.
No, it was partly financial. We're looking for savings in a budget where we had to come up with a lot of savings, but also from a policy perspective, we couldn't justify the difference between the two settings in terms of the policies. It would, it just didn't.
Completely different patient population.
Yeah, but the whether or not a bed hold day is a problem won't vary according to the nature of the patient. It is whether or not if there's a tension for use of those beds that would result in a person losing their access to a bed, yeah, that creates a challenge. We didn't think that was an issue.
So you're not concerned about any adverse effects around lowering the threshold?
No, I'm not concerned about it. So to me, that policy has always been questionable, but not just in DC, but nationwide. Now, others will argue with me that it's desperately needed. Maybe even some folks on my staff, but I think it's not like we cut them to zero. We basically equalized it with what you see on the skilled nursing facility side.
Okay. Healthcare Finance noted a $2 million in local savings in the FY27 budget for long-term care services by shifting payment structure to quality, not quantity. So some advocates have raised concerns that a bundled payment structure could lead to across-the-board pressures to reduce personal care aid service hours. How will Healthcare Finance ensure that beneficiaries with high needs will not lose their PCA hours?
And sure, and that's something that we're still deliberating internally as well. But the goal, and this was raised in one of our stakeholder meetings, our goal really, as you mentioned, is the quality over quantity and also recognizing that each individual has their own care needs, right? We believe likely that a bundled rate approach will allow a provider and the individual and or their family supports to really think about what makes the most sense in terms of care. We do see a lot of personal care services utilized here in the district. Folks need it. We want to provide it, but there are other services that are available that aren't going to, necessarily not going to rehabilitate someone to like 20, but really can give you a better quality of life and function in terms of physical therapy or occupational therapy that can be supportive. Or we can look at, or what we're looking at is also like what kind of supports do we see that our residents want? Part of the vendor that we did bring on board did not only a provider survey, but also a beneficiary survey, and really just trying to have a better sense of what people appreciate, need, and want, and try to make that available to them.
Okay. Is this Telegen that you're referring to?
No,
No. Okay.
the vendor that worked on the rate study.
Okay. All right. Okay. Now I do think we're done. Okay, great. All right. So I want to thank our government witness. Okay. I want to thank our government witnesses for testifying today. Obviously, Director, it's not goodbye, but I do want to publicly thank you for your years of dedicated service to the District of Columbia.
Thank you.
I don't know how many times you've testified before the council.
I've been here since 2011, so.
Okay, well, this is just budget. We'll see you for oversight and some other hearings before you get out of here. But thank you so much to all of you. And again, thank you to your team for making yourselves available a couple of weeks ago to answer some of the questions that we had. But also the constant communication about a variety of these different things. My colleagues often say like, oh, healthcare, that's complicated, but y'all got it over there. And I'm like, I wish, we're holding on, but also, yes, it's complicated, and also it's expensive. So we are definitely doing our best on behalf of serving the residents in the district and making sure that people can continue to have affordable and clear coverage. Okay, so for the public, this concludes the budget hearings for the Committee on Health for the proposed fiscal year 2027 budget. The committee will meet again on Wednesday, May 20th at 3 p.m. where we will consider and vote on our committee's budget report recommendations. And then it will proceed to the full council thereafter. So I think the deadline already passed for public witnesses to submit their written testimony. I think it's today at 5 o'clock before the record closes, and you can do that by written. There being no further business before the committee at this time, the time is 12:24 p.m. and this hearing is adjourned. Thank you.